Great. So welcome everybody. I'm very, very excited to be here. This is Ein Be'ein's second session in this special webinar. For those who were here last week, so I'm happy to see you again. And for those who are new to us, welcome. I'll say a little bit about Ein Be'ein for those, just to remind you, and for those, again, who weren't here last week. Ein Be'ein is an Israeli mental health professional group that was started after I visited Ethiopia a few years back, and I came across the situation of autism, the autism community in Ethiopia, and understood that there was a big gap between the needs and what exists. And therefore, I started Ein Be'ein with the purpose of training professionals in Ethiopia to work with autism, with autistic children and their families. And over the time, I gathered a very great staff, which includes, one of them is also Mr. Moshe Manhiem, that I will introduce soon. And together we are working on bringing you different types of training, getting to know you and your needs. And I invite all of you here, again, to contact us at the end of the session or whenever you feel relevant, to let us know how we can help and what we can do to further along and develop this great community. I'm going to share the, one second, I'm going to share the, here we go. Okay. Moshe, what do you see now, just to make sure?
No difference.
No?
Has not changed.
But what do you see now?
Just the Ein Be'ein logo.
Just the Ein Be'ein logo. So 1 second. Let's do this. Okay.
Now it's you.
Okay, now?
Just the logo. First, it's the first PowerPoint.
Yeah, the first, it should, 1 second, move. Here we go.
There you go.
Okay, great. So last week, we had our first session, as I said, that was about understanding the basics of presentation and diagnosis in ASD. And we got very good feedback, so thank you to you all of those of you who filled out the questionnaire. It's very helpful to us to understand better. This week is our second session that we're going to learn about the benefits of early intervention. And next week, Thursday, will be the third session, or our last session for this webinar, that will talk about basic behavioral interventions. And I'm very excited. Again, this week, like last week, there's a short form that I would like all of you to fill in at the end to give us an idea of how to continue. And now I will be happy to introduce Moshe, Mr. Manhiem. 1 second, sorry. Okay. So Moshe is been working for over 45 years with autism. He's a clinician that worked in, Moshe, I don't have it in front of me, so you're able to tell me more about yourself, but that worked, he's from Georgia, Atlanta. He worked in the Marcus Center for many years with parents and individuals with ASD. And we are very, very happy to have you here with us. And we thank you very, very much. You're welcome to start.
Thank you, Renana. Welcome, everyone. I'm going to jump in. I want to make the most of our time. My understanding is that we have another hour and 5 minutes approximately. I'm going to try diligently to stick to that. You are welcome to ask questions at any time. You can put them into the chat box, and Renana will interrupt me as appropriate to respond to them. Don't be shy. It's just fine to put your questions up. You don't have to wait till the end. Also, one of the important things, I'll talk about this at the end, but I'll mention it now. One of the important things that people who are treating people with autism and people who have family members with autism benefit from is community. To that end, we invite you to turn on your cameras because it's valuable and important for you to know one another so you can recognize your faces, and create this community of support that is so very much needed for people with autism. So just to review what we're going to do today, I'm going to briefly review what we did last week and then start talking about early intervention. Specifically, we're going to talk about physical therapy, speech and language therapy, and occupational therapy, social skills training, all the things that early intervention tends to include. I'm going to talk about the role and function of neuroplasticity in assessing children with autism. And finally, I'll talk, have a brief word about the burden that all of these challenges have and the needs that are demanded upon the families, and the importance of the professional community bearing that in mind. I'm going to detour first into the unique needs of people with higher functioning autism, and specifically the question of savants that came up last week. Just a quick review of the definition of autism for anybody who might not have been here last week. And I think that the slides can be available, the PowerPoints can be available through Ranana if you want. And we're working on getting a YouTube channel put up so that these lectures will be available to the broader community. Autism encompasses delays in social communication and social interaction. They commonly include language acquisition and delays, atypical use of language, difficulty understanding nonverbal communication, a lack of eye contact. And again, we're not talking about the cultural eye contact that I know happens in many communities, including my understanding in Ethiopia. We're talking about the natural kind of eye contact that young children spontaneously do. And how people with autism struggle with the development and maintenance of peer relationships. I like the language that the Diagnostic and Statistical Manual put out by the American Psychiatric Association uses, which is, quote, deficits in social emotional reciprocity. I think that's a very cogent phrase. The second component that is very commonly seen in people with autism are restrictive and or repetitive, called stereotypic behaviors that are not age appropriate, that commonly include ritualistic looking behaviors in play or repetitive self-stimulatory behaviors, and frequently an over interest in specific topics or subjects, hyporeactivity or hyperreactivity to sensory stimuli, the five senses, that people can be over responsive or under responsive to those things. Let's go to the next slide. We're going to talk quickly about high functioning autism. We talked about last time that people with higher functioning autism may not display all of the language acquisition challenges frequently found in the lower functioning population. Their challenges, the challenges that people with high functioning autism display more clearly are the difficulty in developing and maintaining social relationships. That is often a very, very distinct component. I'm going to talk about the use of the word Asperger's, which you may or may not be familiar with. In the West, however, the word Asperger's is quite common. It was used because that's the name of the German physician, Hans Asperger, who first identified the syndrome in 1944 in Germany. in the middle of World War II. He was doing work with people with autism. He is not an uncontroversial figure. It's a separate discussion. That term was officially used by the DSM from 1976 through 2013, when the DSM-5 placed it under the category of the broad category of ASD, autistic spectrum disorders. The rationale for this change is complex, a little bit technical. I'm happy to talk about it further in the question and answer period if you would like. Just let us know. The reason I bring this up at all is because in the West, I don't know if this is true in Ethiopia, the term Asperger's is still very commonly used despite the guidance of the DSM to discontinue its use. So if or as you hear or use or were taught the term Asperger's, it's not a high crime. It's just something that officially is called high functioning autism. And we'll talk about that a little bit more. Given people with high functioning autism frequently have strengths in language, and they commonly have average to above average intellectual skills, many professionals and educators minimize or ignore parental concerns about their child's presentation and any other symptomatologies that qualify it for inclusion as an ASD. Commonly, you'll see this population still having this severe rigidity, ritualistic behaviors, sensory issues, the lack of eye contact. They often have very few friendships, sometimes none at all, which is not to say that they don't desire friendships. It's just that they often present with enough social awkwardness that peers often lose interest in relating with them, relating to them. These children are often quite cerebral. They often have specific and sometimes very unique areas of interest that can appear somewhat academic, and sometimes, due to their poor understanding of social cues and social norms, they can come across as arrogant. They can appear abrupt, rude, which of course complicates their social relatedness even more. Nobody likes to be friends with someone who's a know-it-all, or who only wants to talk about one subject, or who is, rude. That's a normal thing, and certainly for children. Adults may have a little bit more tolerance, but children frequently are much less tolerant for that level of behavior. The question about savants came up last time, and individuals with autism across the board may have, they're about 10% of them may have some kind of savant type presentation, some unique skill. I'm reminded of a client I had who had very, very good computer skills. And the parents said, they kept on talking about how good he was at doing the things he wanted to do with computers. The area of deficiency for that young man happened to be with the fact that he couldn't do things kind of on demand. So if there was a specific task that you wanted him to do or needed him to do, even though his intelligence was uniquely strong in the area of computers, he might not be able to perform that task. And one of the things that is important in terms of having great or unique skill is, can you do it when you need to? And that need is really defined socially. If I need you to do something, if I say to Renana, I need you to do this now, and she maybe hears me but doesn't respond, that's a problem. And frequently, the 10% of the autistic population that have these savant, sometimes called twice exceptional skill, the exceptions being that they have autism and they have these unique talents. If they can't do them when necessary, that's a problem. Some of the strengths that the people with high functioning autism often have in that savant kind of category is hyperlexia, a unique ability to read fast, accurately, and with high levels of comprehension. They may have perfect pitch or a high level of musical memory. I've had clients like that. They may have a broad exceptional memory that they just have an almost encyclopedic recall of things that they hear, read, or learn. They may have advanced math or calculation skills. They may have very, very strong visual, spatial, or an encyclopedic recall of certain topics. I remember, again, for example, a young man that I was in high school with, and that would have been like over 50 years ago. He got up on the board before class started, before the teacher came in, and he drew a map. I lived in the New York City area, the suburbs of New York, and he drew a map of how to get from New York to Boston and back using not the highways, but all these side roads. He had a very, very sophisticated memorization of all the maps and all the roads and what connected where. And it was a quite intricate thing that he just jotted down as if you were going around the corner and you were showing which roads you might take to go from here to your local market or something. And I think that was a good, I didn't know until many, many years later, I didn't put together that, oh, Billy was a guy who probably was on the autism spectrum, because he had an odd presentation, but we didn't have that language at the time. So that's a good example of that visual spatial strength. The frequency of what are called prodigious savants, people who are neurotypical, who just have these broad abilities, and who are not on the autistic spectrum, are, as I understand from my research, exceedingly rare. These are people who have these unusual talents in two or more areas, and their numbers are so extremely rare that it's not really necessary to include. They're statistically insignificant. I think one of the things I looked at said there's only about 100 such people in the world. I'm not quite sure how they came up with that number, but that's what I saw in my research. Let's go to the next slide. Since I just started discussing percentages, I thought I would toss out a little bit more just to help you get some perspective about things. Of the entire population of children who qualify with an autism diagnosis, about 70 to 80% of them have speech and language delays. 30% approximately are either nonverbal or minimally verbal. And again, those children are frequently, I'll talk about this again later, they're frequently relatively easy to spot because at an age that we would expect them to have language, they have no language, oftentimes very little emotional connectivity. They look at you the way they might look at the chair in the room. So there's not a sense of relationship, as we talked about in more detail last time. The DSM, the diagnostic manual, states that there are 3 different levels of autism. Type 1 would be the high functioning autism, people that we've just spent time talking about. And that encompasses about 40 to 50% of the total population of autism. And that's defined as needing mild levels of support. Frequently, this population can live independently or with some, but not a great deal of support. I've got friends here in Israel who have a son who's able to live independently. They give him support in terms of his finances, but he clearly is on the spectrum. Type 2 encompasses about 25 to 35% of all people with autistic spectrum disorders, and they have moderate needs for support. They may do well in a group homes that have some, but not great deals of level of support. They may be able to work, but they're going to need a moderate level of support. And then the most severe level is the type 3, encompassing about 20 to 30% of people with autism. They need a very high level of support. I have a very good friend in the States. She happens to be a psychologist. She has a child with more severe autism, and he's needed basically institutional care and support his entire life. And he's doing well with that, but he would be very, very non-functional if he did not have someone caring for him, preparing his food for him, cueing him about what to do and when to do it. So those are the 3 levels of autism. Let's go to the next slide. Commonly, people, going back to the high functioning population, also known as frequently the Asperger's population, they have comorbid diagnoses of things like attention deficit hyperactivity disorder and or anxiety, which may end up being a good thing, which you may say that's a curious thing. Why would it be good for somebody with high functioning autism who also has attention deficit disorder or anxiety? Why would it be a good thing for them to have that thing? And here's the answer for that. The reason it's good is because frequently what we're doing is we're treating the symptoms that people have. And that's often the most critically important thing. We're going to talk about that in a moment. And it doesn't matter whether that comorbid delay is in speech or attention deficit or anxiety. There's even a small cohort of the population that as they reach adulthood will develop psychosis and schizophrenia. And obviously, if you're dealing with a presentation of psychosis and or schizophrenia, psychiatric intervention, overwhelmingly including psychopharmacological intervention, is critical. So this is a good segue, a good lead into the discussion about early intervention. And specifically the question I left you at the end of our last meeting, which is, do you or do you not need a definitive diagnosis of autism in order to treat it? So I want to be clear about that. Let's go to the next slide. Diagnostics are very important. Having a distinct diagnosis is the preferred and recommended way of leading into treatment. But what if you can't do that? What if, as in many areas, I think this is true for Ethiopia, obtaining a clear diagnosis by a trained professional is hard to obtain, or sometimes, even with a good diagnostic evaluation, the results are not clear. That's not uncommon, even with really great resources. What do you do at that point? Now, again, remember, we're not talking about a broken arm where you can go to the hospital, to the clinic, you can get an x-ray and you can see the break and you can see what to do. Psychological testing, even really, really state-of-the-art psychological testing, provides a snapshot, a photograph of a moment in time of the person who's being tested. Let's say the person who's being tested didn't sleep well the night before, or they're coming down with a cold, or they're not feeling well that day, or they're just it's not, they're not having a good day. That can result in sometimes an unclear or even a misleading result, which is why that observation of these people over time gives us a rich background that we can reflect upon to understand what the diagnostic profile might or might not be. This is, I think, the curious little secret of working with people with autism. We don't treat autism. The underlying condition of autism cannot be cured, cannot be really treated. What we can treat, an important distinction, is the symptoms. And those symptoms are the things that we've talked about already: lack of language, social skills, understanding, nonverbal communication, all these things that we've talked about, we'll talk about more today. Those can be treated. And you may say, well, like, how is it that we're treating the symptoms, but we're not treating the syndrome itself? How can you do that if you don't have a diagnosis? And the way you can do that, even without a diagnosis, is that in very young children, frequently, the delays are so clear that they demand attention, even if you don't have a diagnosis. So now let's go to the next slide, and we're going to get into early intervention in more detail. Early intervention for services for children with autism typically encompasses a wide range of therapeutic and educational supports tailored to the unique needs of the child. As a result, by the way, this is labor-intensive work, which is great for the child, because the child getting treatment is getting very individualized treatment. It's difficult if you're talking about a population in a country of 130 million people. If you do the math, I haven't, that means that the population of people with autism in Ethiopia is going to be relatively high, and providing individualized treatment by qualified clinicians, you're going to need a very, very large cadre of people to do that, which my understanding is not the case for Ethiopia today. We're going to review these services in more detail, but they commonly include speech and language therapy to adjust communication challenges, physical therapy to improve motor skills, and occupational therapy to enhance fine motor skills. We'll talk about that, and enhance daily living skills. And also all of these things, physical therapy, occupational therapy, and speech and language therapy, frequently work on sensory integration problems, and we'll talk about that. Additionally, behavioral support, and we're going to talk more about behavioral challenges next week, is often augmented with behavioral interventions. Classically, this is my background, it's not the only thing out there, but applied behavior analysis, ABA, which is the science of behavior modification, is commonly used to reduce problematic behaviors. It can obviously at the same time promote independence. Other services may involve specialized educational interventions, often done through the school, but not necessarily done through the school. Social skills groups, and family support programs to reinforce the tools and strategies needed. This is a very comprehensive approach that addresses the diverse needs of children of autism, as well as their families. Let's go to the next slide. We're going to talk about physical therapy. Physical therapists address children's motor and developmental needs. It's common for autistic children to appear motorically awkward in their gait, their running, and their gross motor skills. When I say gross motor skills, I'm talking about big motors, motor skills, big muscles, muscle groups, arms, legs, core muscles. Interestingly, though many people with autism have delays with these gross and fine motor skills, which we'll talk about in a moment, it's not a definitive part of the criteria for diagnosis, even though they are commonly found within the population. With tailored exercises and activities, physical therapists help enhance strength, balance, and overall conditioning. They work on developing motor planning and motor control, which are often areas of difficulty for children with autism. These therapies aid the child's ability to perform daily activities more independently, and improves their overall functioning. About 30 to 50% of the ASD population presents with a need for these kinds of gross motor interventions. We're going to talk about occupational therapy on the next slide. Occupational therapy is essential, covering about 50 to 70% of the population that need this. Occupational therapists focus on enhancing fine motor skills. Now, the word fine motor means the more delicate muscles, those things that traditionally were used in occupational trades that classically required the use of hands. Think about a carpenter, think about a bricklayer, think about a mechanic, all of those things where one's hands and the small muscles are very, very important. It also can intervene with problems with sensory processing. We just talked about that last time regarding the 5 senses that we can be hyposensitive or hypersensitive, having a low response or a very high intolerant response for stimuli in the 5 senses. It can also, OT also can help with activities of daily living like toileting and personal hygiene in terms of teeth brushing and washing their hands and face. The issue of toileting obviously is for children for whom toileting is a challenge. It is a huge challenge for the families because our expectation of children is that usually by age 3 or so, certainly sometimes earlier, we don't expect that they're going to be in diapers anymore. And the challenge of managing someone who does not have bowel or bladder control, who is in their latency years from age, call it 5 to 12 or well into their teens, obviously managing those challenges is very, very labor intensive, obviously very, very unpleasant. So these are the kinds of things that occupational therapists, physical therapists, and classically applied behavior analysis and other therapies use, since it's such a high priority. Structured activities and play-based interventions can often be the methodology with which these therapies are done. Sometimes it can be done in small groups, but again, with great frequency, it's done just on a one-to-one basis. And again, having these skills gives the child greater independence, gives the families much greater independence, and allows for improved participation in various social, education, and home environments. Let's move to speech therapy on the next slide. About 70, as we said, 80% of people with ASD have speech and language delays. Now, note, we talked about 80% of the people with need language, speech and language. We talked about 50% to 70% need occupational therapy, and 30 to 50% of the population needs physical therapy. That there's a lot of overlap. A lot of the individuals with autism need all of these modalities. Again, it's very labor intensive, and we're going to talk soon about what do you do in a situation that many countries are in where they don't have the professional complement to provide services. I'll be quite honest, even in the United States, where I spent 65 years, today, the volume of need for these services far exceeds the ability to get these treatments provided. Children on the spectrum need great volumes and great skill in these three treatments: physical, occupational, and speech therapy. Back to speech therapy. There are many people who have many different kinds of speech therapy challenges and delays that have nothing to do with autism, but what everybody has, if you have a speech and language delay, regardless of its etiology, regardless of its source, they all need speech and language therapy. With maybe self-evident, speech and language therapists provide communication and language support and training commensurate with the needs of the individual. They, again, are providing very highly individualized services, working on improving both verbal and nonverbal communications, helping children better ways to express their needs, their thoughts, their emotions. They can work on articulation. They can work on expanding vocabulary, and that sometimes hard to define quality of sentence structure and using the language the way native speakers of that language uses that language. And really, that's the goal, is to help children approach a native level of language use. All of these therapies, speech, physical, occupational, what they all have in common is working on the entire constellation of deficits that ASD children tend to have. Recall last time we talked about the pervasive developmental disorder, that what's pervasive are the basic things that we expect children to be able to accomplish by the age of 3. We expect social and emotional development, we expect language development, and we expect kind of typical play development. When these things are not there, then they need frequently this cluster of services to help remediate them. One of the first things I learned about autism when I was first exposed to and working with the exclusively with it, is that at its core, autism is about communication. Communication, not only in terms of whether there's speech, but also communication, as I mentioned last time, as in terms of whether there's a relationship. Think for a minute in your own social world, how much communication you engage in that has nothing to do with words, where you have uh, uh, the way you look at someone, the way you gesture, not in a way that's rude, it's very, very socially appropriate. I see it, I'm aware of it because I worked for so many years in the area. We do a lot of communication like that. So communication being a core issue of autism is not just about speech and language, it's also about the nonverbal communication and the ability to interpret what nonverbal communication is. There have been interesting studies where children with autism are given different kinds of cards with facial expressions that you and I would commonly recognize as fear or surprise or joy, things like that. And children with autism were frequently, the verbal children, unable to put the right word with the right expression. So they have to be taught that. By the way, while we're talking about basic lessons, I'll toss in another basic lesson that I learned about autism many, many years ago, which is a bit of a conundrum, which is that if you've seen one child with autism, you've seen one child with autism. And what does that mean? It means that people on the spectrum, even though they may have these kinds of deficits in common, they may manifest themselves in many, many different ways. And one of the things that I've learned over the years is that the breadth of presentation that might be included under the diagnostic umbrella of autism is fairly large. Now, I'll also put in a caution to that. I'm very personally, I'm very particular about using the diagnostic criteria that we have. And I have been surprised at some of the use of the diagnosis of autism that have been given to certain people. I'm not sure I agree with it all the time, but it's a free world. People can claim diagnoses as they want or assign diagnoses as they think is fit. But sometimes I wonder if there's some creeping of the diagnosis of high functioning autism. That's my own 2 cents. Even though if you've met one person with autism, you've met one person with autism, it can be difficult to discern the subtleties between someone with autism and someone who just may be a little bit socially awkward. It takes some practice and some exposure to be able to see those nuances and see the commonalities, to see the differences. And that's something that one can only get with time. Let's go to the next slide. Actually, I'm going to pause here and see and ask, are there any questions thus far? I don't know that I see any in the chat box, but again, you're welcome to put any questions you may have in. We're going to talk about social delays now. As we've talked about, social skills, the ability to engage socially at an age-appropriate level is a significant area of delay for young children. They often have difficulty understanding and engaging in typical social interactions. Services for these kinds of delays commonly include structured social skills groups where children may practice taking turns, playing a simple game, or sharing their experience, or having games in which they are cued to share what they think, what they like, what they do. They may need help understanding social cues in a controlled and in a supportive environment. Therapists and educators often use role play. They may use visual aids and other activities, games, to teach children how to initiate conversations, how to respond appropriately to someone who's initiated a conversation. I know a young man here in my community that whenever I say hello to him, I know that he's on the spectrum. Whenever I say hello to him, he frequently looks at me, hears the hello, but has to be prompted to say hello back. And so I'll say, I said hello, cueing him, what do you say back? And he will give me, sometimes a bit gruffly, a little of attitude, hello. So he'll do it, but he needs a cue to be reminded that what we tend to do when someone says hello is we respond with hello. Children may need to be taught how to appropriately respond to different social situations. Doing this, teaching these children these skills increases their ability to interact with peers and enhances their social integration. Also, consistent reinforcement and practice in real life settings, such as play dates, playtime, classroom environments, they are essential to helping children generalize these skills across different domains. These kinds of social skill groups can be run by any of the therapists that we've talked about, physical, occupational, or speech therapists, but also they can be run by educators, they can be run by other mental health providers, and all of these things really provide a kind of 360 treatment for children with autism. One of the things that yes, please.
I'm gonna interrupt you. There are 2
Please.
questions in the chat box.
Please, I'm ready.
Okay, so Dr. Marin asking, she says, my question, if you can share us your practical experience on early intervention, what you really do, starting from which age? How do you manage as children at the early age may not enjoy structured activities?
Right, which is part of the challenge. You're trying to teach someone something that they don't. Remember last week, I used the phrase, my own phrase, I've never heard anybody repeat it, so I don't know that it's so applicable, of not being sure that the software, so to speak, was downloaded. Let me take a minute and respond to the doctor's question. It's a very, very good question. And I'm going to talk about this more in a second. I'll talk about it now, and I'll skip over it when I get to it in the presentation. We need to trust parents. Parents know their kids better than anyone else. If a parent comes in, we talked about this a little bit last time. If a parent comes in with a child at, let's say, 9 months of age and says things like, my child doesn't look at me. My child doesn't like to be held. Those are curious things. What we need to do is fairly quickly try to begin to provide that child the stimuli to help them maybe tolerate the sensory experience of being held. Now, there's nothing wrong there. There are plenty of people who don't like hugs, but babies like hugs. That's just normal child development. If they don't, that's not the clue. first of all, what I'll talk about instead of my experience, the research shows, and again, it's very difficult to do double-blinded research with these kinds of presentations because you can't structure the pool of candidates in exactly the same way. But the research that we do have shows that early intervention is definitively more helpful in creating the an improvement in the outcome that these children have. They still may have delays, they may still have challenges, but they do better than if we didn't treat them at all. And part of that has to do with plasticity. I'll get to that in a minute. I'll delay that one. One of the most difficult things for a physical therapist, occupational therapist, or speech and language therapist to do is engage the child with the tasks that they want them to do. The classic, most basic rule of thumb is to accept the client where the client is at. So if the child, let's say a child with very severe autism, no language, they sit and they rock or they self-stimulate in ways that's totally detached. What some methodologies suggest is to sit with that child and mimic their behaviors, rock with them, self-stimulate with them, and offer them things to use that they like, that they're self-stimulating with, or things like that, to try to get their attention so that they see you're interested in the same things they're interested in. That may not work all the time, but it may work sometimes. Engaging some of these children is admittedly very challenging, but that's why we have speech, physical and occupational therapists. That's what they do, is that they learn how to engage with the people. And also the behavioral therapists. I mentioned in passing the applied behavior analysis. They are experts at learning about what motivates a child and how can you use what motivates a child, learning their preferred activities, preferred toys, preferred things to do, so you can leverage that into teaching them the things that you're trying to teach them. It can be very technical. Sometimes the people lower on the spectrum, a higher level of need, sometimes they're much more difficult to engage, but it is doable. I've seen really amazing things. I'll talk about one example, and this is a digression, but it's a great example. I'm going to make it very short. We had I think he was about a 16 or 17-year-old young man with classic autism, virtually nonverbal, very minimally verbal, and he had diabetes. And this was a while ago. And in order to treat him with diabetes, they had to stick his finger to get a drop of blood to see what his blood glucose was. Well, he didn't like being stuck, and his family couldn't accomplish that with him anymore. So we brought him into treatment, and the applied behavior analysts had him in a room, and they provided him certain kinds of reinforcement. In this case, it was an edible, something that he could eat that was consistent with his diabetes diet, but also reinforcing for him. And they very gradually introduced to him the little machine that would stick his finger. Literally, they sat at the doorway, and when he saw it, he became uncomfortable, but they gave him the edible, the treat to eat, so that he would be reinforced for tolerating the presence of that device in the room. And they continued that step by step, literally over the course of weeks, until they got him to the point that he could tolerate it being touched to his finger without sticking it. And then ultimately, they taught him how to tolerate the stick. It's uncomfortable, but for those of you who've had a finger prick, it's not horrible. And it was painstaking work. They did a brilliant job. And that's just finding out what's reinforcing. So you need a high level of training in order to accomplish these things, but they can be accomplished. So that's a large digression into the doctor's question. If there are other questions, let me know. Otherwise, I'm going to continue because I'm aware of the time and wanting to cover these things. The other thing in terms of social skills activities that can be helpful are things that naturally happen in the community. Houses of worship, churches, mosques frequently have youth activities. Schools frequently have youth activities during or after school. And these are things that children with autism can frequently participate in. Now, it's important for the leader of the group to know that they've got a special needs child in the group so that they can help with that. And it's generally very valuable to have a support person, a one-to-one support person, help that child in the group. And care has to be taken for that child to be safe, because children can be they cannot understand children with other developmental issues. They can have very significant misunderstandings, and sometimes they can be mean. So we have to protect the special needs child from being the victim of that kind of behavior. And we also want to teach the typically developing children, this is how you interact with someone with special needs, because they're part of our community, they're part of our family. Let's go to the next slide and talk about neuroplasticity. Neuroplasticity is at its strongest in the first 3 years of life, which again goes back to the question we had about why do we intervene as early as possible when we see these delays. It continues with less strength through adolescence, and it loses even more abilities in the mid-20s, to my understanding. I'm not a neurologist. This is what I've read. And even into the senior community, there's still some neuroplasticity that remains, but it's generally accepted that the younger a child is, the more capable their brain from finding workaround solutions to the challenges they face. So just providing remediation isn't really we can't start too soon. We really want to start as early as possible. No child suffers from an exposure to speech, language, physical, occupational therapy. There's no detrimental effect to it. And if the child begins to approach age appropriate levels of functioning, then you don't need that service anymore. And it's as simple as that. I mentioned earlier that, like many other neurodevelopmental disorders, we're not directly treating the disorder, we're treating symptoms. And I want to just use the example of a child who might have cerebral palsy, where they have brain damage within the first years of birth that may lead to very significant motor neurological delays. When that child is getting physical therapy, or speech and language therapy, occupational therapy, sometimes even surgery, are we treating the cerebral palsy? Or rather, are we treating the symptoms that the cerebral palsy has left? And it's the latter, obviously. And those, again, that's another function or another application of the neuroplasticity that finds workaround skills. It's the brain's ability to change and adapt, which is why we see the volume that a typically developing child learns in their first 3 years, maybe first 5 years, is more, I've read, don't know that this is actually statistically true, but it makes sense to me, that a child in their first number of years of life learns as much as they will learn until their death. The volume of learning that happens up until age 3 or 5 is so stupendous that, and that's all attributed to the brain's ability to adapt and change. We know from the literature that children who are unable to acquire language by the age of 5 to 7 are not likely to be able to reach a native level of language functioning, and they may be forever impaired. So if for no other fact than this, we want to provide really early intervention. We want to be aggressive about that.
Moshe, there's another question.
Please.
So George Yesh, sorry if I'm not pronouncing this right, Yesh is saying in some countries such as the US and parts of Europe, intervention is not always permitted without a formal diagnosis, and insurance often does not cover therapy expenses. As you mentioned in your presentation, and I tend to agree, intervention can sometimes begin prior to an official diagnosis. However, should we initiate intervention based solely on symptoms? My concern is that we need to rule out medical conditions and consider potential comorbidities before proceeding. How do we reconcile these considerations in practice? Thank you.
That I will refer George back to our first lecture, in which I said explicitly, I will repeat again, medical evaluation is always the first step. Having a child, if you have a suspicion of developmental delays, go to the clinic, go to the pediatrician, go to the nurse, and say, my child is having these challenges. I reviewed, and I will refer him back to those things. There are genetic tests that sometimes are pertinent. There are other medical tests that must be done. I agree 100%. I'm going to pass on the discussion about European and Western services for children, simply because we're talking about the Ethiopian community. I don't disagree that there can be difficulties, but I think that that's a little bit outside the boundaries of what we're talking about. I'm happy to stay late if others want and have this discussion, but I do want to move on because I think it's just a little bit to the side of the target audience that we have. But it's a very fair comment. Like I said before, and this is really consistent with what George asked, we want diagnoses early as often as possible, but they can be difficult sometimes to obtain, either because finding clinicians is difficult, as I mentioned, or because we don't have a clear diagnostic picture. Treat anyway. I think that that's critical. If you see gross motor delays, get in there. You see, that they can't use their fingers the way typically a child at that age would use their fingers. Or if they're having eating issues, a lot of kids with autism have problems with that. All of these things deserve attention. Let's go to the next slide. My understanding is that even in Addis Ababa, that there's not yet the breadth of services to correctly meet these needs. And if that's the case, I'm my guess is it's much more in the outlying communities. So then the question is, what do we do for these children? How do we provide practical direction to the families that have these children? Parents don't intuitively know what to do to help their child, to help remediate the challenges that their child has. And this is where I go back to trusting parents, which is what I covered before. Parents know, extended family frequently knows when there's a delay. Because of the labor-intensive nature of these challenges, what do we do? In the research that I've done, I've found that there are programs that are initiated in what are called LMICs, which are low and middle income countries, programs such as the PASS and the PASS Plus programs that are used in India, the CST, the Caregiver Skills Training Program in Pakistan through the World Health Organization, and Uganda's parent-mediated interventions via community health workers. Bangladesh has a community-based rehabilitation program. The common features of these programs are task sharing, where they train non-specialists to deliver interventions and support, parent-mediated interventions, where they're empowering caregivers to intervene, integration into existing systems, where they're using the schools, health centers, or other community groups to provide supports and services. They're low cost, they're scalable, they're culturally appropriate, and they have local ownership. If they're community-led, they have greater sustainability. I'm a clinician, I'm not a public health professional. That being said, I can't emphasize strongly enough that these kinds of programs may be the best investment that Ethiopia can provide its special needs community. If there's anybody listening, or if you know anybody if anybody who's listening knows someone who is connected with the government and with policy, or if you yourself have these connections, I believe investigating these kinds of interventions could be the best investment on a macro level that the country can do to intervene and improve the quality of life of this population. Let's go to the next slide. I'm going to talk a little bit about family stress, because that's really the fulcrum that where it counts. That's really where everything comes together. Recognizing and addressing a child's needs, one's own child's needs, is heart-wrenching. I don't think there's a parent of a child with autism or any other developmental delay or chronic medical problem for that problem who has not shed tears in their journey. Coping with what is often a slow pace of progress in treating the ASD population and the many behavioral challenges that can be present is a gargantuan task. It's so difficult, and the need to support primary caretakers is huge. Having a broad family support, a broad social network of people who can assist with childcare and the child's needs and the family's needs provides an enormous help to the family and the primary caretakers. It's important to remember that these children need such a large amount of time and consistency that all the caretakers and the whole social network really needs to be on a team. And we're going to discuss about some of that next week. I just want to emphasize this last point. Even parents with the best understanding and acceptance of what their child's needs are, providing their child's needs is exceptionally stressful. Marriages suffer. siblings frequently feel left out due to the disproportionate amount of attention given to the child with special needs. So thus, anything and everything that can be done to support these families should be done. Only a family that has endured the profound amount of stress that these children brings, they can understand what other people's go to, which is why this networking, I think, is so valuable, because people understand from their own experience so well, and with greater compassion, I think, than anybody else can. So if there are other questions, I got in barely under the wire of the quarter after the hour limit. If there are questions, please let us know. And otherwise, I'm happy to see you next week. Any other questions? I'm looking now. Thank you, Pragna. I saw that. What is SLP and OT? SLP is speech and language therapy. OT is occupational therapy. Yeah, speech therapists, synonymous, the same thing. Right. So that was answered. Right. Right. That was that. Okay. I don't see any other questions. I will give it back to Renana.
Thank you very, very much, Moshe. I could say that this was very interesting for me, and especially the part that you talked about what you can do in Ethiopia, even though you don't have all these resources. So thank you for that, and I want to thank everyone who participated today. Again, we are very excited that this is finally happening. And we're really looking forward to next week for our third and last session in this webinar. I put in the chat box, I put a link to the form that I would really like all of you to fill out. I will also send it via email to all of you, hopefully. Hopefully, if I have your emails. If not, please write to me now through the chat box. With a recording of this Zoom that, again, was fantastic. Thank you very much. And I hope to see you all next week. If there are no more questions, you're always welcome to write to us through the email or WhatsApp. And that's it. Have a good weekend.